while we take our seats here, I just wanted to share the gentleman sitting up on stage. This is called the Foundational Hall of Fame. So probably do a quick intro and then we'll just dive into a couple questions. This one will not have sort of an audience portion, so we'll just have a nice banter up on stage. But the gentlemen you see up here represent over 100 years of value-based care commitment in the space when you add up their tenures. And when I think back to my early days in organizations and getting to know heads from tails on these types of care models, outcomes, resident experience, and journeys, it was largely the output of these three gentlemen here that kind of guided my path. And we thought it was a great session to sort of close out day one in acknowledging these three leaders for their tenure and their continued support of the space that we all love and spend time in. George on the far left is today a national medical director with Molina Healthcare. Prior to that, George led and founded a program called Care Connect MD, which does high needs reach ACO work amongst other types of care models in the space. And prior to that, largely led one of the most successful institutional equivalent special needs plans in the country at CareMore Health from 2008 to 2015. Tom Coble, who sits in the middle, was the first person I had ever heard of that was launching I-SNPs out of his own nursing homes. And I fondly remember meeting Tom in Dallas years ago and leaving Dallas with more questions than I came in with, because I'd never heard of a nursing home's conviction to start their own health plan. And he did it, and he did it really well. And today he actually now is the Chief Strategy Officer at American Health Plans. Thank you, sir. And Jason Furman, to my immediate left, who today I think is announcing a new role. Just recently announced president of Care Connect MD, also at Catamaran Health Solutions. Jason was the founder and first venturer, you could say, into the ACO space when he, amongst others, launched LTC ACO. And so, again, the three of them, just with some quick intros, represent sort of the Mount Rushmore, if you will, of institutional special needs plans, institutional equivalent special needs plans, and ACOs in the space. And why we're talking about that today, why that matters today, is not just to help all of us on our journey, but it's actually kind of a commemorative time. So in 2003, the last little history lesson was the Medicare Modernization Act was passed. And what that did is it allowed, in 2006, Medicare plans for the first time ever to create special needs products. Prior to 2006, Medicare plans only created a single product. But those products need to be different, right? A 65-year-old needs very different things than a resident in your community. And so with this sort of round robin and round table and just Q&A session we're going to have, it's also in honor of the 20-year sort of anniversary of the Medicare Modernization Act, giving birth to the ability for seniors in your communities to select different types of health plans with different benefits and different care models and different solutions. And so many of the folks you see on the stage today really gave life to that. Here we are. So with that, why don't we just start left to right? So George, the first question that I think myself and many have in the audience is, you know, in 2006, we were all doing a lot of different things. But how did you, amongst your leaders and your organization at that time, how did you get your leaders to stand by your conviction that this was the right space to venture into when really nobody had prior?
There we go. Okay, show of hands. How many of us have frail elderly parents or grandparents or aunts and uncles? Keep your hands up if your hand is up. How many of you get a call from their primary care doc every month? Anybody? No. How many of you get a weekly visit? Does your mom or dad or grandma or grandpa get a weekly visit from that primary care clinician? Anybody? So in 2006, CareMore Health Plan approached me. I was in this space practicing medicine every day. I'm a family doctor. And, they said, George, the special needs plan, huge opportunity. Is there anything you can do here? Yes, there's a lot of things that we can do here. And I want to have a ratio of 80 lives to one primary care clinician, a nurse practitioner, or a physician assistant. I want to do weekly visits. I want to become part of their family. I want to become part of the family's family. I want to become part of the family of the facilities where they live. They wanted to throw me out. They thought I was crazy. They thought I was nuts. But one leader in that whole group, and literally every physician leader of that whole team, completely said no. Too many specialists, too many, back and forth to the hospital, too expensive. But one non-physician said, let's give this a try and try this model of care. And guess what? We got fabulous outcomes on the other side of it. It was a miracle that we pulled it off. And I could talk for an hour about it, but I'm going to just keep moving, Jim.
Well, same question to Tom. So, back in 2006, tell us a little bit about your life back then, your communities, and what provided you the conviction to know that this is where you wanted to head, launching the first provider-sponsored plan.
I came out of the oil and gas business into the nursing home business without ever having worked a day in my life in healthcare. So a friend of mine, after 8 years of negotiations in a duck blind, convinced me that I should get in the nursing home business. So I had been going through in the oil and gas business, and my job was to evaluate delivery systems, pumping systems, different things, how to measure offshore natural gas, a lot of different things. So that background is really what led me to what ended up being the hunt for an I-SNP. So when I got in the nursing home, the first facility that we bought with my friend was, it wasn't Medicare certified. So when the facility became Medicare certified, you watch the staff get different training, different things to open a skilled unit. And it became crystal clear to me that if we could change Medicare to manage our patients, then we could keep them out of the hospital. And so I started in '95 and talking to people about it. I'd fly all over the country and try to find people to talk about it. They kept saying, what do the actuaries say? What do the actuaries say? So I did a quasi-actuary study myself. And it showed that we could, if the rules were changed, that we could reduce hospitalizations by 65%. And so I'd show that to people. They didn't believe it. First thing they thought, kind of like what George said, what does some oilie from Oklahoma know about managed care? And I mean, you just talk about knocking on doors. I knocked on every door I could find, chased people down. Eventually, I didn't want to own an insurance company. I wanted to run the operations on the ground. And so I was looking for an insurance partner. And finally, in 2003, when the MMA was passed, they called me the next day and said they wanted to do it. So we went live in August of 2005, and we operated it very successfully. We outperformed the 65% that we thought. I had 6 facilities by that time, and our staff loved it, our residents loved it, our families loved it, medical directors loved it. It was a great plan. The model of care we developed was really good. And so in 2014, I ended up having to buy the insurance side of the business, which sent me on the hunt again for another insurance partner. And I ran into an old friend of mine, Mike Bailey, who built some plans across the Southeast back in the early days. And so Mike and them were now running a nursing home company. And so they were getting ready to launch one in Tennessee. I had two going and another one fixing to start, and we merged our companies into American Health Plans. And Mike became the CEO, and I became the strategic planning officer, and it's been a great ride. We operate in 14 states now, and we'll be 15 and 26, 17 and 27. And currently have almost 10,000 lives, and we'll bust through that in a big way after the first year.
Wow. Well, congratulations, both getting out of that duck blind and then starting all that you started. Jason, slightly different variable, so ACOs go live with MSSP in 2012. How did you and your partners at LTC ACO get that off the ground? Because that was a mighty challenge back then to think about underwriting only a nursing home population with those benchmarks. But how did that come about?
Yeah, well, I think to start off, it's important to note that I spent almost 20 years in Medicare Advantage, and we also had an I-SNP. So I had plenty of experience there. And I remember when the Affordable Care Act came out, and I was reading about MSSPs, the first thing that came to me was these are just mini Medicare Advantage plans. And the company that I went to that ended up being kind of my primary investor, my main investor, where LTC ACO was born out of, was in the nursing home business. And they were very enthralled at that time, as Tom said, with I-SNPs, and being someone that ran a 200,000 person MA plan and just knowing I-SNPs can grow slow and they take a lot of, any insurance program takes a lot of capital. I went back to my thinking from 2010, actually, and said, why not create an I-SNP on a fee-for-service platform? And by doing that, it required very, very, very little regulatory capital. We were not an insurance company. We did not have to build out a network. We did not have a lot of compliance restrictions that Tom and others have, and we didn't have to pay claims. So there are a lot of things, and we could grow. We didn't have to grow one by one. We grow by physician groups. So since leaving LTC ACO in January, I started my own advisory firm, helping other companies think about this. And then, as you mentioned, I was recently appointed president of Care Partners, which is a subsidiary of Care Connect MD, where I met George many years ago. And so we're in the process of growing out an MSSP program there. And, one of the things I wanted to point out that it's not germane to your question is, these programs generate a lot of money. LTC ACO, since inception, generated $190 million worth of savings to CMS. You can assume that 50 to 75% of that went to the LTC ACO, of which half of that went to physicians. I don't think there's anybody in here that received a check. We hadn't yet leaned into the senior living space. But if I was sitting in front of nursing home operators, there'd be very few people raising their hands as well. And that's simply because they didn't lean into value-based care. I think back to the very first presentation, and you talk about all the work that value-based care takes. I mean, you've got nursing staff, you've got people investing time in behavioral health, And what's the return for that? And the answer today is almost nothing unless you can get yourself aligned with a value-based provider, whether that's an I-SNP or an extended institutional special needs plan, with Medicare Shared Savings Program or ACO REACH program. It is imperative in my mind that you all receive compensation for work that you're being asked to do. You've got real estate, you've made money off the real estate, you've got plenty of residents, they need care, we all know they need care, you need nursing staff, that takes investment, and where's that money going to come from? In my mind, it's going to come from investing in the care delivery model and aligning yourself with a value-based care entity that can provide funds to help support that initiative.
Yeah, great points, Jason. And I guess it'll sort of tie into the next question. You know, when you think back to the early days of launching I-SNPs or ACOs, it was probably awfully hard to get access to the type of data to make these models make sense. You know, when you look out in the audience now, just based on kind of Jason's input, as well as some of the talks you've heard today around social isolation, models around depression, you know, how to get started, and really knowing what levers these communities can pull around ER diversion, inpatient avoidance, coding. Like, think about these tools now, and we'll just kind of go down the line, but how ought plans and ACO partners be thinking about, you know, not just care delivery action, but even prospective, working with these groups, mining their data, and coming up with a roadmap? You know, George, do you have any thoughts on that?
Sure. So I worked really hard to figure out how to predict who was going to fall, who was going to need that next hospitalization or ER visit, or who was going to die in the next year, in the next 6 months, or next month. And, you know, I couldn't figure out a way with all the data that I had access to, and albeit it was nothing as sophisticated as we have today, but I couldn't figure out who was going to, you know, decline in a week-to-week basis. But I needed to figure that out if this model was going to work, to have one clinician, primary care clinician, for every 80 lives that we, you know, got to see. And so that was hence the reason for the weekly visits. I remember telling, you know, people, well, 95% of the visits, you know, we're not making a single change to the plan of care. But I won't get to the 5% or so that will change without seeing them weekly. So I'm going to see them weekly. It's the right thing to do. And, you know, they thought I was crazy. Why do you have a 1-to-80 model? Why don't you go to 1-to-160 or 1-to-120? You know, that kind of thing. But, you know, the model breaks down because you don't become part of their family. You don't have time to call, you know, the family's family. And you don't have the ability to connect with the caregivers that are right next to the patient, the staff that are at the facilities, in a way that is up close and personal. And so, you know, that's what we did. It wasn't data driven. It was do the right thing driven, and the outcomes that followed on the other side of that followed that.
Yeah, great points. You know, Tom, similar question to you. You know, being as that you still operate buildings, given that you know, still are in the risk space on the plan side, you know, what are the data points that are most meaningful for you all now? Or action points that you all are really leaning into now, or maybe you weren't back in the early days?
Well, you know, in the early day, like George said, I knew this would work. I knew it was the right thing, so that's why I pursued it, you know. Eventually, though, you have to have the data to get to a certain point. And that's when I did that, I call it quasi, it pisses actuaries off, that I call it a quasi-actuarial study. But, you know, it was enough to prove that if you did these interventions and you did them the right way, that it worked. And to George's point, you know, you can't, we use nurse practitioners in our plan, and they're probably 1 to 60 to 80 somewhere along the line. But, you know, a lot of physicians use them, and, you know, they expect them to see 20 patients a day. We only expect them to see the patients that need to be seen. And I think that's the way most I-SNPs operate anymore, and different things. So you have to have the data, and, you know, in the assisted living space, it's the next frontier, I think, for I-SNPs. George was way early. I had one in Oklahoma only because my mother lived in our assisted living and I wanted her in our plan. But
Good reason.
and she lived.
That's
a
one hell
long
of a market
time.
expansion strategy right there.
Mom marketing strategy.
Yeah. So, but I think now it's becoming clearer as to, because it's all around hospitalizations at this point. And I'm starting to, with our own, you know, I call my facilities, I have one assisted living, I call it the lab. It's where we work on everything. And so I think I'm beginning to see a way that if where assisted livings can work with I-SNPs, and the value that they can derive, it's like Jason said, they need to be paid. And the value that they can derive is all going to be in preventive, proactive medicine. And that's what this I-SNP that we developed was about. It was all preventive, proactive. So that's how I see how once we get to partnering with assisted livings in a way that we can do that, I think there's a very good chance that they can really become an essential partner in the next frontier.
Yeah, and for me, I take a bit different tact, and I use the term, we're very data-centric. I've always been data-centric. It's called waking up the ecosystem. So at the center of our ecosystem are physicians. Physicians may not all be great business people, but they're smart people. Nurse practitioners are smart, inquisitive people. These are folks that are very data savvy and want the data in their hands. And when you do that, you do it the right way, they can make a difference, at least I believe, at the bedside. That doesn't always work out the way that you envision it just because of other technological barriers. But I do believe that data is an imperative in the delivery of better care for the patient and better quality outcomes for the patient. I do believe that technology in the future is going to play a greater role in delivering care to these patients. And whether it's, you know, at the provider side or at the senior living side or the nursing home side, everybody's going to need the right data in their hands to make the right decisions for these people.
Yeah. Well, I'm going to see if I can go to a reliever here and call in my comrades up there in the press booth. Any questions come in or anything worth asking up there? Because I know the audience is really who's driving the rest of this discussion.
Well, I have a question. And so selfishly, I'm going to say I submitted the question, Joel, and then I'm going to read it. Approved? Okay. George, Tom, Jason, we're super grateful that you guys have kind of charted the waters for us and have gone out well ahead of so many of us in this space. And now we're all here because of a lot of the work that you guys have done. But as you guys know, this space and territory that we're operating in is consistently evolving and changing, and we know that there's a huge amount of influx in population, and the number of people who are needing to live in our communities is going to grow significantly over these next 10 years. Like, what really excites you guys? You guys have seen around the corner. You guys were early in a lot of this stuff. When you guys think of the next 10 years as big population growth that's coming, what excites you guys about what we can do in this model?
What excites me, Andy, is the fact that, at least from where I'm sitting, we're just now leaning into the senior living population. And that senior living population is dealing with folks that 20 years ago were in nursing homes. And it's encouraging to me to hear today and to hear from operators just the resources and the thought process being put into the care delivery system in a non-healthcare, in natural healthcare environment. I think that there's an evolution there that excites me, the growth notwithstanding. I mean, growth should excite all of us, but it's the evolution of what's happening really in this industry that creates a huge amount of opportunity for both residents and for operators.
I mean, and just like feedback, that just excites me, right? I mean, you have operated in this space for multiple decades, serving the person who's currently living in my community. And for the past decades, you've been seeing them. And you're saying that what you see in our space is this really uncharted territory for us to really step in. And this is where we have to have this bias for action, this offense moving in this direction. We have people who are validating it, who've been living this for multiple decades.
I mean, we're leaning into it knowing that right now it's not necessarily a total healthcare system. I would hope that the industry begins leading into it, knowing that they're being forced to make investments in healthcare delivery, and this is a way to get paid back for it.
I mean, who couldn't be excited to be in this business if you look at how many people are starting to turn 80 and as they come into it? I'm very excited. I mean, what we've been able to do, like I say, I call our nursing homes the lab. We've built an AI dashboard that we're getting ready to release that does exactly what George was trying to do years ago. You just didn't have AI. And we're able to predict at the first sign of when we need to intervene with a member, with a resident, with a member of the plan, to be able to keep them out of the hospital. And I think as we go on and with AI, because we're going to have to be more efficient, we're not ever going to have enough nurses, and we're going to have to, the government's not going to have enough money. So as we all work together on this, we need to be able to keep looking ahead, trying to develop something new, go where no one's been before. And because people are going to be living at home, we're living in assisted living, they're going to be living in our facilities, but the ones in our facilities are just going to be coming for short stays, I believe. They're going to be living in assisted living and in the community.
George, take us home. 10 years from now, what are you going to be thinking?
How many of you guys feel that your parents or loved one, or even your own families, yourself and loved ones within your own family, actually have the care you desire match the care that you really receive? I mean, think about it. It doesn't happen all that often in American medicine today. And I would suggest that it is very possible today to match care desired to care given. It is happening in spots around the country today, but it certainly isn't the standard. But it is very possible to be the standard. And I see 10 years from now where it is the standard. I see where, you have clinicians that are empowered at the bedside to actually, see somebody holistically, body, mind, and spirit, and all that means. I loved that previous presentation. It was, hit it out of the ballpark, so to speak. But it was so real and so true. And that empowered clinician giving true informed consent, and that empowered clinician giving true informed consent when they're part of that patient's family, that family's family, that facility's family, it's very possible to actually match care desired to care given as we go forward.